No, it looks good.
Okay, good. So this was a lecture I initially made as my resident grand rounds in residency last year. There haven't been a whole lot of updates since then, but some of the information I might gloss over if it's not as relevant. So the goal is basically to understand the history, diagnosis, and management of CNS paraneoplastic disorders. Probably don't need to spend that much time on the history. An objective is kind of review the history of cancer and paraneoplastic disorders, describe the most common and significant paraneoplastic disorders of the central and peripheral nervous system, really focusing more on the central nervous system today, because there are a lot of very specific syndromes in the peripheral nervous system, and it'd really require a whole another set of lectures. Kind of review how we test for them and what the limitations of that testing are. We can kind of go over the evidence for how to treat them. So, I like to start with some general background history. This is the Edwin Smith papyrus from the 17th century BC in Europe, where if you've ever curious what cursive hieroglyphics look like, that's that on the left, and this is the print on the right. It's the first mention of cancer in the literature. Basically, it was a trauma surgery text, but they mentioned breast cancer, the exam findings, and that the surgery at that time was not curative. Which I just thought was interesting. I can kind of gloss over some of this. It's not directly more relevant. The first description of a paraneoplastic disorder was by Armand Trousseau, who's a great physician who had Trousseau syndrome named after him, which is this. She described a special crasis of the blood, which irrespective of inflammation favors intravenous coagulation, which he noticed primarily in cancer state. And that's a lot of flowery old-timey language for a lot of inflammatory blood clots in cancer patients, which we will call Trousseau syndrome or migratory thrombophlebitis, which is seen in a lot of adenocarcinomas, which he eventually discovered in himself years later. The first possible description of paraneoplastic encephalitis was by Dr. Hermann Oppenheim in 1888. It met all the clinical presentation, but the brain biopsy was negative, and it's not clear what this patient actually died from. Just to kind of give you a timeline. And then the first definite paraneoplastic neurologic syndrome was in 1890 by Dr. Auch in France. I have no idea how to say his name, but he did a lot of EMGs on patients with cancer and noticed that there are a lot of neuropathy in these patients, and there was no other cause that he found. So he felt it was likely due to something related to their cancer directly. Now that was in 1890, but the Derek Denny Brown in 1948 actually described a progressive sensory neuropathy, which turned out to be a neuronopathy associated with lung cancer. It wasn't until 1985 where Dr. Gross et al. Here actually discovered the anti-Hu antibody, which was the cause of that. The first paraneoplastic antibody was not discovered until 1983. So now that and since then, there have been dozens and dozens found. I'm sure you've seen the panels we order with a ridiculous number of things on them that we're never quite sure what to do with. And this is generally the problem in working up a paraneoplastic disorder. So just a general definition, the National Cancer Institute defined it as a group of symptoms that may develop when substances released by some cancer cells disrupt the normal function of surrounding cells and tissue, which is a very vague definition. But we're basically looking at pathology associated with cancer that's not due to its direct effects. So not metastasis, not just metabolic derangements and not eating enough, not infections or chemo-related treatments, but just something related to the cancer somehow. So the general pathophysiology is somewhat complex. So I'm going to try to give a simple overview of it here because I'm not an immunologist and I probably can't explain it the best. But the basic premise is that the cancer cells are abnormal and your immune system doesn't like it. And this is one of your body's defenses against cancer. So they have antigens on them that are abnormal and your immune system picks up on that. So either they die and macrophages or dendritic cells pick these up and present them to CD4 cells or CD8 cells, or they're picked up directly on the cell surface by CD8 cells. This leads to activation of B cells and plasma cells, which then create a lot of antibodies in the CNS directly, or direct invasion by CD8 positive T cells who cause direct neuronal cell death. And this is an important distinction about the pathophysiology because it does kind of affect the treatment, which we'll go into a little bit more later. But that's the general idea. You have these abnormal antigens that your immune system uses to defend against the cancer, but unfortunately, they look too much like something on your nervous system, and the nervous system ends up getting attacked. So how do we know this is true? Why do we think this is true? So the one of the more common ones we see, and which is kind of used as a model system for a lot of what we're talking about today, is NMDA receptor encephalitis with ovarian teratomas. So it's been noted that ovarian teratomas are a mixture of a lot of different type of tissue that's not supposed to be there. One thing that you can see in there is a neuroglial component where cells are kind of like non-functioning, white matter and gray matter mixed into this stroma of random other stuff. What we see on the pictures on here, the left for A, B, C, and D are all immunohistochemistry against, and it basically NMDA receptors, showing that in these ovarian teratomas, that receptor is expressed in this, this neural tissue. The bright colored ones, EFG and HIJ, are basically immunofluorescent staining. E and H are for a GFAP, a glial marker. GLUN1 is basically the NMDA receptor subunit. So that's more of a neural marker, and then they merged them all pretty. This study was basically looking at to see if that pattern was predictive, but there's no like control and regular here. It's just kind of showing that the ovarian teratomas actually have neural tissue with these antibodies in it, which we've noticed. And when they looked at this tissue, tends to be an inflammatory infiltrate. So it's something that we know that exists. We know that the immune system doesn't like it. We know there's B cells and T cells, there's antibodies. And then they're just, they stated that the expression of the GLUN1, the receptor subunit, was more associated with the encephalitis, which would make sense. So knowing that tissue exists, that we do have mimics of your nervous tissue in these tumors, we still have to show that it actually causes problems. So this is another set of stains that I picked mostly because it's pretty, but this is looking for different antibodies against the cerebellum. So there are different layers in your cerebellar cortex. We're mosely looking at Purkinje cells here. If you look at the top right in B, they're kind of outlined very pretty in green, where you have, there's kind of a diagonal slant of them with the cell bodies on top and the big, root-like branches of them kind of going towards the bottom right corner. So we know that these antibodies that we find in patients with cancer do bind to the cells. So the top left one is the anti-Yo antibody, which was the first one discovered, also now called Purkinje cell cytoplasmic antibody, because as you can see, those circles are the Purkinje cell cytoplasm. So it's very specific to that. And you get a very specific syndrome with it. But take that in comparison to D on the bottom right, which is the anti-Hu antibodies, which are just generically a neuronal nuclear antigen, and just basically everything lights up. So you can't really see different layers or different cell types or different parts of the cells because everything is lighting up. It's just attacking all of them. And we also know with anti-Hu, there are a lot of different manifestations of that possible disease. So, we know that the tumors have nerve-like tissue. We know the immune system doesn't like it. And we know that that leads to antibody formation against parts of your nervous system. And then the other part of it we talked about were T cells causing actual cell death. This is a more immunofluorescent stains, basically looking at, looking for cytox, which is a measurement of cellular breakdown, and anti-Hu antibodies. So basically what it's leading to in the top left is that the anti-Hu antibodies are being taken up by these cells, and then the caspase staining in blue and the cytox staining in green show that they're basically being attacked by T cells, and therefore the membranes are opening up and they're dying. So this is kind of demonstrating that you actually get T cell mediated cell death because when you apply the anti-Hu antibodies to neural tissue. This was done in rats, not in people, but they were able to show that is a direct result of that. So all of this kind of supports that general scheme we have, that antigens in the tumor lead to immune attacks against the nervous system. And that's the basic model kind of we use to think about these disorders and to go about diagnosing and treating them. So I mentioned some other common antibodies here because they do tend to come up. This is more just because it's interesting. These NMDA receptor, LGI antibodies, voltage-gated calcium channels, glycine receptors, these are all cellular membrane antibodies. They're extracellular. So what happens is the antibody will bind to it, and then those become non-functional. They get internalized. The cell doesn't necessarily die, or at least not right away, but you get loss of function in that cell, and that's what causes the symptoms. So in NMDA receptor encephalitis, those receptors tend to be clustered in your medial temporal lobe. So you end up getting seizures, you end up getting memory deficits, you end up getting changes in mentation. There's a whole host of things you can get there. But we don't have to go through all of them. But these are just some example ones that we end up testing for a lot. So in kind of how to think about diagnosing them, I'm sure if you've ever been a part of trying to diagnose someone with a paraneoplastic disorder, it ends up being very difficult. There's not really a lot of specific tests, with some exceptions, and there's no tests which are by themselves really sensitive and specific. We end up having to do a lot of tests and a lot of ruling other things out. And it just ends up usually being very difficult and very expensive. So the general idea of how to think about it is, first starting with your history exam, do you have a neurologic syndrome that fits some paraneoplastic disorder? So, we're focusing more on encephalitis here, but it can be neuropathy, cerebellar degeneration, myasthenia gravis, or, Lambert-Eaton myasthenic syndrome. There are a lot of different individual syndromes that can be paraneoplastic, but may be one of a lot more common mimics. And then you kind of guide your testing based on what that syndrome would be. So in the case of central nervous system disorders, MRI, lumbar puncture, EEG, lab testing can all be helpful. The EMG is really more for peripheral nervous system disorders. It's not necessary for all of them, but it's as it's a nerve test, it won't help you with the CNS, except for maybe ruling stuff out. And the antibody testing that we do, it can be non-specific a lot of times, but it's also not fully understood. And there are a lot of real associations with multiple antibodies, but there are a lot of spurious ones as well. So you don't have to read through this entire chart, but basically this is looking for, this is someone proposed diagnostic criteria. This is kind of the schema they went through. It's kind of an example one to going through step by step. I think it's probably simpler to think about it in terms of limbic encephalitis being the most common, and really the tests and criteria here kind of cover other CNS disorders as well. So they proposed definite autoimmune limbic encephalitis all four of the following criteria are met. You have to have a subacute onset within 3 months of working memory deficit, seizures, psychiatric symptoms, suggestive and involving of the limbic system, bilateral brain abnormalities suggestive of this, which should be in the medial temporal lobe, and either CSF with elevated white blood cells, or EEG with temporal lobe abnormalities, and ruling out reasonable other causes. They wrote this for autoimmune, but this is kind of also how we think about paraneoplastic as well. And it's not entirely clear how different the disorders are pathophysiologically, whether or not there's a tumor, which we'll get into a little bit later as well. They also proposed, sorry, it froze for me, probable autoimmune encephalitis, which uses the same findings, but the same clinical presentation with just some of the that previous workup, but not all of it. This is generally how people work these up, but not a lot of people really use these criteria very stringently. The problem is with these patients, a lot of times you'll get fairly non-specific testing, even in cases of, you know, paraneoplastic or autoimmune encephalitis. You know, that seems really consistent with it. They get better with immunotherapy. You know, you find a tumor and you look back and what their testing showed, they may not have any antibodies positive, although that's not part of this schema. You know, the MRI probably showed just something vague. The CSF had like 3 white cells, and it was just through a high index of suspicion that it was treated and diagnosed. But these are kind of the best criteria that we have. And they do slightly differ in peds, because pediatric patients kind of often will have a more subtle presentation, which is hard because this is already can be a very subtle presentation. These are just some example peripheral paraneoplastic disorders. We don't have to go through them in too much detail, but just to kind of give an example of all the different syndromes that can be out there with the tumor associations. You know, myasthenia gravis is probably the most common thing that we think about and see in neurology. And there is a pretty strong association with thymoma, although it is a minority of patients. And then I think Lambert-Eaton syndrome we probably see every now and then around here as well, which is also very frequently paraneoplastic, but just not as common as myasthenia. So, you know, that kind of, we kind of went over the general thought process on evaluating whether or not someone has a paraneoplastic disorder and what the basic tests are we should be getting to rule this in or rule this out. So often, essentially always when we're considering this, we're sending like antibody panels. I know there's a lot from Mayo Clinic, there's a lot from Quest that just have, you know, 10, 15 different antibodies that come back in titers. And it's always, it's usually difficult to interpret those. Basically, what you have to do in this scenario is it's generally recommended to send the panel, not to try to pick out the individual test you want, because it's really not as one-to-one as we would like. But when you get this panel back and there's something positive on there, we have to kind of ask ourselves, is this a reasonable explanation of the clinical syndrome, or is there more likely something else going on? The problem is if you just assume that if any antibody test comes back with any kind of positive, there's going to be a lot of false positives. One, because we send a lot of antibodies. Two, they do tend to be prone to false positives. And three, a lot of these antibodies will be positive just for having the primary cancer and not necessarily for having the paraneoplastic disorder. So there's some notoriously that come back positive at low titers, and you just, it doesn't always seem to fit with the clinical syndrome and you're not really sure what to do with it. But if you do have a specific syndrome, especially with a specific antibody, that can help guide your tumor workup. So just to kind of go over some of the specific issues with antibodies, you know, anti-Hu antibodies and anti-Hu encephalitis and neuronopathy are fairly well described in the literature. But if you were to test any random number of people for this antibody, there would be some people that have it, and those people would be more likely to have undiagnosed lung cancer than they were to have any kind of neurologic issue. In fact, if you did test positive, you would actually be reasonably worried about having small cell lung cancer. If you tested everybody with small cell lung cancer for anti-Hu antibodies, the people who turned up positive the vast majority of them would not have any neurologic issues. It's actually only a small minority of the patients with small cell lung cancer and those antibodies that have a paraneoplastic syndrome. Now, we do have, you know, laboratory evidence, you know, that I went over earlier, that those antibodies can be pathogenic, and we have a clear mechanism. It's not clear why some people have the paraneoplastic syndrome and some don't, even when they have the antibody, which would kind of suggest that the antibody itself does not cause the problems, but the antibody in concert with the cytotoxic T cells is really what's causing the neurologic issues. Another one, anti-MA2 antibodies have an association with multiple cancers, but they are actually predictive of recurrence of small intestine neuroendocrine tumors, even though I think, you know, the classic neurologic issue with them is paraneoplastic disorder with testicular cancer. But they kind of have other uses as well. potassium channel antibodies and acetylcholine receptor antibodies, the ganglionic ones, just often show up positive to low titers. I've seen this cause issues with patients who believe they have an autoimmune disorder or paraneoplastic disorder because they keep having this like barely positive titer, and it's just common in the general population for unclear reasons. You know, they can be associated with disorders, but it's usually with 10 times as much as what you see in some of these low titers. And then I did find one Portuguese study that was just retrospective, looking at, you know, what happened with everybody referred for paraneoplastic disorders. How many of them actually had them, how many had the antibodies. So 882 patients over, I think, like a 10-year span were referred to be evaluated for paraneoplastic syndromes. Only 68 of them actually had positive antibodies, and only a quarter of those actually were diagnosed with a paraneoplastic syndrome. The other 3/4 were felt to have false positives. So generally, I think if you've worked up a fair number of these disorders, I think that probably would fit with a lot of personal experience, that you work up a lot of people for it before you actually find a real paraneoplastic syndrome, because they are pretty rare. And I think it also goes to show that the antibody testing can definitely be confusing because even when they're positive, a lot of those people will not have any paraneoplastic disorder. But it's one of the better tests that we have, and why we have to kind of combine the whole milieu of all of our tests to see what makes the most sense, and if we can rule anything else out to kind of get a best idea of what's going on with the patient. But it's certainly it's something that's very challenging to be confident that someone has a paraneoplastic disorder instead of just ruling everything else out and trying steroids. Here's an example of a lot of antibodies that have been demonstrated in CNS disease. You don't have to read through this or memorize it. Just an example kind of showing how far we've come over the past 30, 40 years in all of these antibodies and known cancer associations and multiple clinical associations as well. Some are more specific, like the anti-EO antibodies. Some, like the ANA1 and ANA2, can really show up anywhere in the nervous system. But it's definitely very interesting from a research perspective. So here, this is some EFNS task force screening guidelines. This is a little outdated now, but I don't think that they've updated them yet. Generally speaking, we end up kind of, at least I think in most places, you end up just scanning people top to bottom to see if you're really suspicious, looking for everything. Most of these screening guidelines are kind of met with a chest, abdomen, pelvis CT or a PET scan, ideally a PET scan. But for ovarian and testicular cancers, ultrasound can tend to be more helpful. It's probably not important to memorize all these guidelines, but if you find someone with a specific disorder and no known cancer, it's worth kind of seeing what the screening guidelines are, because it's not uncommon for patients who do have a paraneoplastic disorder to have a delay in finding a cancer for up to 2 years. I don't know if it's the majority, I don't actually know the numbers offhand, but it's a very large number of patients actually have the paraneoplastic disorder first and not the cancer first. This kind of goes by specific tumors, but again, you'll see that you know, a body CT or PET covers most of this, except ovarian and testicular cancers, which have either an ultrasound and some lab testing that's worth adding. But again, you know, it's more that if you find a specific disorder, then it's worth double checking these screening guidelines if you can't find a tumor. Also for, you know, how long you should be screening afterwards, because often the answer is at least a couple years. Just some highlights for screening. Again, if you have NMDA receptor encephalitis in a young woman, you should pretty aggressively look for ovarian teratomas for a long time, because there is such a strong association. The same with women in anti-EO cerebellar degeneration, that breast and gynecologic malignancies have a very high association, and they'll need to be watched very closely for that. Anybody with anti-HU antibodies should be looked at for small cell lung cancer, kind of like we talked about. whether or not they have any other sequelae of that. There is also a strong relationship between DNER, also known as anti-TR related cerebellar degeneration, and Hodgkin lymphoma, but that's a lot rarer. MA2 in a young man, you should be looking for testicular cancer. And as a general rule of thumb, if someone has a paraneoplastic disorder and a cancer, and both are under control, if they relapse with a paraneoplastic disorder, you have to restage the cancer, because the expectation would be that if it's with an association with a cancer, the relapse of the paraneoplastic syndrome is because of relapse in the cancer. It's not 100%, but usually that is the case. So what do we do about these? This is kind of a difficult question, but also there's not a ton of options, so it ends up being only a few choices. So we don't have to go through all of these in detail. I went over them in a lot of detail because it was the grand rounds, but they're not all super helpful. Basically, there was a study in 2000 kind of taking anti-Hu and anti-Yo patients to try to treat them with immune therapy to see if they improved at all. The problem with this study is all of these patients had the disorder for a long time and had pretty significant neurologic deficit by the time the study started. They gave them IVIG, high-dose steroids, and cyclophosphamide. Nobody got better. A few people stabilized, and then a lot more people got worse. It was a small study, it was only 17 people. But if you'll notice, both of these syndromes are with intracellular antibodies and thought to be T-cell mediated. And generally that means that there's actual neuronal cell death and destruction going on. So even if you were to stop the immune infiltrate, you wouldn't really expect them to get better once there's a lot of neurologic deterioration, because you can't really bring those cells back. And that kind of is what they saw. No one really got no one got better. Some people got somewhat stable, but most people just tended to keep getting worse. This is another one looking at anti-MA2 antibodies that also kind of had a mixed bag. I don't think that's a very important study. And this is more just a general patient trial for Plex in paraneoplastic disorders that were not Lambert-Eaton or myasthenia. They just looked at 20 patients who had some disability but were not horribly disabled. 40% showed stability or improvement at 6-month follow-up in patients who had an underlying tumor. So not wonderful, but it is some effect that looks, because they'd all been progressing for the year previous of starting the study. So then we get into more studies with NMDA receptor encephalitis, which, although rare, is relatively more common, and therefore we can actually get some big numbers on it. This was a bigger treatment trial, which involves steroids, IVIG, Plex, rituximab, cyclophosphamide, azathioprine. It was all retrospective, and it was whatever the treating physician wanted to use. And it wasn't specifically looking at immunotherapy effects, but it does have some interesting data to help think about these disorders, not just the treatment. Just to go over the graphs, on the left is kind of a bar graph that looks at comparing tumor treatments and non-tumor treatments and how well they did. So the first one is tumor patients who got cancer treatment early. And the blue is patients who recovered or only had mild deficits, and the red is severe deficits or dead. So you can see that patients who were treated aggressively for a primary cancer did pretty well. The next one over had late or no treatment for their cancer, and a lot more of those patients ended up with severely disabled or dead. And then the patients who did not have any cancer actually had the highest proportion of poor outcomes. Which kind of makes sense if you think about it. If this is really caused by some other cancer, if there's no cancer to treat, there's no kind of source to get control of. It's just a primary immune system issue. And it turns out that that's a little harder to get control of. The graphs on the right are just kind of looking at measurements of antibodies. Patients who did better tended to have, with treatment, tended to have their antibody titers lowered. So it does show some evidence for actually monitoring at least this antibody over time in patients to see if they might have a recurrence. And they also found that there was a lot higher antibody titers in the CSF than there were in the serum, which is why we also often test on both, if not just the CSF. But I don't know that that's necessarily been shown in other antibodies, but this is kind of the data we have. So this is what we go with. This is a similar study, retrospective study in children and adolescents, which use kind of the same treatments. Overall, 29% had a full recovery, 45% had significant improvement, and 8% had limited improvement. The rest did not improve, which is more looking for functional status, again, showing probably some benefit of the immune therapy, although they weren't comparing them at the time. So this is probably a more helpful study from 2013, which I think guides some of what we're doing nowadays. So it's 500 patients that they followed for 2 years and looked at both with neoplasm and without. And what they found in this, what they used was first line, which is what pretty much everyone uses, are steroids, IVIG or Plex. Usually high dose methylprednisolone, like 1 gram daily Solumedrol, with either IVIG or Plex, sometimes sequentially, sometimes mixed up. There's not a lot of rules around it. So some people will combine them as a treatment. Some people will try one then the other, but that's some combination of steroids. IVIG and Plex are considered like the first line, not Plex and IVIG, because the Plex will just take all of that right out of your blood, but one or the other. And what they did in this study was consider rituximab and cyclophosphamide as second line agents if you did not get better with that. So, 48% without tumors and 39% with tumors failed first line immunotherapy, which isn't great. And in this study, the presence of a tumor did not have an association with any kind of different outcome. But what they did find was that if you weren't responding to the first therapy, then you did do better switching to a different immunomodulating agent. So if someone's not getting better on steroids or IVIG or Plex, you should switch them to rituximab or cyclophosphamide. And that's, I think, a helpful finding in that, there is, the evidence does show there's a benefit to the first line agents, and the evidence does show that there's a benefit to the second line agents. So at least we have that. The other thing which kind of supported the patients with neoplasms doing a bit better that we saw in the other study was that if there was an underlying neoplasm, that tended to have a lower relapse rate than in a primary autoimmune issue, which kind of fits that, if there's some source of your immune system attacking your nervous system, getting rid of that source makes you less likely to have an ongoing issue in the future. But there's really no randomized controlled trial. There's no like blinded treatments. So it's not the ideal evidence to say what's the best treatment, which is why you often have a lot of leeway. It does, but from what we have from the evidence, it shows that patients with paraneoplastic and NMDA receptor encephalitis do improve with treatment of the tumor and immunotherapy. Treatment of the tumor does lead to better outcomes earlier rather than later. And immunotherapy does seem to have a response. We should generally be starting with the high dose steroids with or without either IVIG or Plex. Although, it's generally considered acceptable to just start with steroids because they work right away and you can get them right away. And then, people will often switch to IVIG or Plex. And then if it's going to be needed long-term, they'll have a different agent more for maintenance. But if they don't respond to that, then either cyclophosphamide or rituximab chosen by the treating physician did lead to improvement. So there are multiple lines of effective agents at least, but there really aren't any direct comparisons between any regimens. This is all just based on what they decided to do with the patients, and they seem to have some positive effects. So there's not a lot of specific trial evidence to say you should be treating them one way or the other, although people will generally try to focus their treatment on what they would suspect the pathophysiology would be if they really think it's antibody mediated, when, rituximab, which works more on antibody production, would be thought to be a better agent than cyclophosphamide, which may have more effect on T cells. The other thing we don't know from these studies is, the patients that has had tumors, nobody, split them up into getting immunotherapy or not. So we really don't know how much of effect is from the treatment and how much effect is from the treatment of the cancer. It's just not really clear. But it seems like both play a role in these patients. So this was another study that looked at just earlier IVIG. We'll go over briefly. They did look at some T cell mediated disorders with the goal of treating them early on in disease, which was not done kind of in the earlier studies. They were really small studies, but most patients did have stability, which may support that even in the T cell mediated disorders, there's a benefit of immunotherapy early, even though the same treatments later on in the course did not seem to be beneficial. Although there's not a lot of alternatives, to be honest. So that may kind of support that still treating them the same way can be beneficial in some circumstances. The overall evidence would kind of support that for any given patient, you really don't know how much they may decline after you're seeing them. So even if you don't see a huge improvement, there may be a significant benefit to preventing worse deterioration, at least with these agents. To try to kind of summarize the way we're treating these, the most important thing, treatment of the underlying cancer. That it'll lower the relapse rate. They do have decreased deficits, better control of any paraneoplastic syndrome. Antibodies against extracellular antigens respond the best to immunotherapy, most likely because the neurons themselves are still working and can kind of heal after the inflammation's brought down. But those syndromes with antibodies against intracellular antigens, especially at a certain point that they've been going on, there's neuronal destruction, and no amount of steroids is going to bring that back. So you may be able to stabilize those, but generally we're not expecting someone who has a lot of cerebellar degeneration on their MRI to have a lot of improvement in their ataxia with IVIG or Plex, because even if we stop the immune system from acting up, the cerebellum is still really damaged, which is unfortunate and very difficult. And it also seems, we didn't go over specifically the evidence for this in this talk, but the antibody depleting strategies do tend to be more effective on peripheral syndromes. Plex and IVIG both have that effect, as does rituximab, but they don't seem to be as effective of decreasing antibody titers in the CSF. And the significance of that is not known for every disorder, but we do know for NMDA receptor encephalitis, it does seem like there's some relevance of that in the disease. So it's hard to say exactly what the effect of that would be. They do seem to work better on peripheral disorders. Rituximab is the same way, although it does seem to have efficacy in these studies. There's some question of, is it crossing the blood-brain barrier? How much effect is it having? We really don't know, because the evidence is kind of limited due to the rarity of the diseases. We kind of talked about the T cell disorders with intracellular antigens may improve or stabilize when treated early, but probably not when treated late. And there is no class 1 evidence to guide treatment for most of these disorders, especially the central nervous system ones anyway. So the treatment protocols vary a lot, and really the optimal strategy is not known. But at least based on the evidence we have, we kind of have a way for going about treating them with the steroids, IVIG and Plex first, and either rituximab or cyclophosphamide second. I feel like most people lean towards rituximab, but there's not really a right or wrong answer beyond that the data can tell us. So that's what I have on paraneoplastic syndromes. I hope that was helpful and not completely nonsensical.